everybody. Thank you for joining the Dialogue on Aging, and greetings from the entire Providence Healthcare family. Just wanted to say we've been through a lot the last almost 3 years now, and it is a new sort of vista for healthcare now that COVID. We do have the vaccines. A lot of us have had 4 or 5. I would really encourage you to keep your boosters up. As we go into the fall, we have seen that not being active and not being social has had, a lot of detriment, especially on a lot of seniors. So we do have to sort of get people back into doing things. It is a little striking to go back into inside spaces, maybe without a mask on. So, but it is really important to keep active. So if you still feel uncomfortable getting outside, getting infections outside is actually very rare. So to be able to do things and then keep your vaccinations up to date. So get that booster if you're due for the COVID vaccine, and definitely get your flu vaccine. They're available in the pharmacies now. A lot of them have walk-ins. I think it's really important if we can keep healthy in terms of avoiding infections, but also keep the things that really are important for wellness, and that's physical activity and social activity as well, and getting to see your friends and family right through the winter. So good luck. Have a great winter and a healthy one. And I'm looking forward to this today.
And hi, good afternoon, everyone. Like Mary Lou said, my name is Margaret Lin, and today there's 3 of us joining you today, and we're really excited to share with you about frailty and social prescribing. So I'm going to share a screen here. You able to see the screen right now? Yeah? Okay. So like Mary Lou mentioned, there is Dr. Grace Park, who's with us right now, and there's myself, and there's also Sandi Temple, who is working directly in social prescribing and bring us some very nice stories today. And so we are going to start the presentation right now. And I'm going to let everyone introduce themselves too as we get there. And mainly what we want to share with you today is the first bit by Dr. Grace Park on what is frailty and how can we prevent that. And then we'll learn about social prescribing, what it is and all about it, and what is happening right now in BC and in Canada right now. And then the last bit, we want to share with you how social prescribing can help you. And then this part will be presented by Sandi with a bunch of lovely stories. So to get into our first part, we want to share with you what is frailty. And I'm going to invite Dr. Grace Park to introduce herself a little bit more and also to talk with us about frailty. Grace, could you unmute yourself?
Hi, can you hear me all right?
Yes.
Yeah, so I do have problems with my internet, and I hope it's going to come through okay. I'm hardwired in, so it should be okay. But anyway, I'll just carry on. And do you have the slides there, Margaret? Okay, so go ahead. So hi, everyone. My name is Grace Park. I'm a family doctor in White Rock. And I've also been working with Fraser Health for the last 12 years as a medical director, overseeing home health services and community health services from Fraser Health to support seniors to remain independent in their homes for as long as possible. So frailty is a topic that I've been involved in over the last number of years. And so today I just wanted to share a little bit of this as a background and then go on to the social prescribing, which is a topic that's very exciting for all of us. So to start, we are in a lovely part of the world living here in Canada, and life expectancy has been going up as well in Canada over the last several decades that we've been following it. And so you'll see the red bar across the top are females, always living a few years old longer than males, but males also life expectancy increasing over time. And this is from 1920 all the way up to 2005. So we are definitely living longer lives. But the bad news is many of us spend the last 8 to 10 years of our lives living with frailty, which decreases the quality of life. Next slide, please, Margaret. When we look at Canada in general. There was a Canadian Community Health Survey that looked at something like 5 million seniors. And they saw in the years that they followed in 2013 to 2014, for a few years, that up to 22% of the people over the age of 65 were frail, using a frailty criteria. And by the time people are over the age of 85, almost 50% were frail. So that's an indication that as you get older, frailty does become more noticeable and definitely affecting people's lives. And more than that, we know that as you get more frail, you need the healthcare system more. And that ends up using a whole lot of our healthcare services. And so that really leads us to worry about the sustainability of our healthcare system. So next slide. So when you get to a certain age, you might see a person needing walking aids, starting to look like they might become frail, but it's not absolutely expected. And aging does not mean that you're going to get frail. And the next slide shows a fellow who's probably the same age as the last slide, but obviously he's fully active and very motivated and staying healthy. And so this is the variability that we see as people get older, that you do not have to get frail. So next slide. Frailty is really important because depending on the degree of frailty, it can actually predict how you're going to do when something happens to you. So a flu-like illness or a small operation or something like that. So if you're a managing well individual at the top green line, you'll have this stressor like the health problem, and it'll take a little while for you to recover, but you recover all the way back up to where you were at, the baseline, and then you carry on. But if you're mildly frail, even if you're mildly frail, you have that insult in your health, and then it takes you longer to recover. So a longer time to recover from an infection or a frail flu. And you'll see that your function does not go all the way back up to where you're at before. And then at the bottom, when you're more severely frail, that's when you take a really long time to try and recover back to your baseline. And you see people like this in the hospital. They never get back to where they were at before hospitalization and often end up needing help, and they become dependent. So next slide. So frailty can be measured actually, and you can actually say how frail a person is if they do have the diagnosis of frailty. It used to be that we just looked at what we call the phenotype, how an individual looks, whether they're losing weight inappropriately, they're slowing in the way they're walking, they're showing weakness, and they're fatiguing easier, they're not physically active. So those were sort of what we call the phenotype of frailty. But more and more, we're starting to become a little bit more specific in what we mean about frailty, what we mean by frail. So in the middle, we talked about the clinical frailty scale. So this is how a person is functioning. So when they're mildly frail, a person is maybe needing a little bit of a walking aid. And then when they're more severely frail, they're actually needing help inside the home with their activities of daily living, like needing helping with their bathing and personal care. And then most recently, we're talking about a frailty index, and that's accumulation of deficits with age, which means that as you get older, more things go wrong with you, with your health. Next slide. But we are seeing in our research and in the literature that early identification of frailty is really helpful because it gives you an opportunity to actually treat those issues that cause frailty and rehabilitate and become more robust and so less frail. So you don't have to continue to be frail. You don't have to become frail if you're able to do some of these things. And that Canadian survey that I spoke about earlier, it showed 22% people over the age of 65 are frail, but 32% were pre-frail. So these people weren't quite frail yet, but they were just starting to get to be that sort of a little bit of frailty starting to show up in their lives and their functioning. And it showed that even the pre-frail people, and certainly the frail people, actually died more readily, and their mortality were associated with that frailty. So even with things like cancers, heart disease, lung disease, people that were frail or pre-frail even tended to have a shorter lifespan. And it also showed that women were generally to be higher risk for frailty, but they live longer. So men tend to be less frail, but they didn't live as long because they had other reasons for their mortality. Next slide. So frailty can present in different ways, and you can even tell in yourself and certainly in your loved ones. You can tell if a person's mobility is starting to suffer, they're starting to need walking aids because of their balance, there's unexplained weight loss, they might have memory problems, needing more medication for medical conditions, increasing support needs, and then starting to become isolated because of these medical conditions and social issues as well. And next slide. So in the healthcare field, we have a tool that we've been using a lot. This is called the Clinical Frailty Scale. And this is used a lot, even in hospitals and certainly by family physicians. And you can see when you've got a scale of 1, this is a person who's very fit. They're still motivated, they're active, they're exercising, and they're probably the most fittest in their health category. And as they get less healthy, so a scale of 3, they're managing well, but they may have other medical problems. And then by 4, that will be what we would call pre-frail. They're starting to get a little bit slowed, and they're still functioning okay in the community, but they're starting to need some help. By the time you get to scale of 5, you're starting to need help with things like transportation and cooking, banking, etc. And by 6, that's where you're starting to need help with inside the home activities like bathing and looking after yourself. So these are the areas where as you get further along, you need more help, but there's things you can do to prevent yourself from getting further along this scale. Next slide. So early identification of frailty, as I said, was really important because as you get older, it's been shown that you actually get 4.5% increase in number of things that go wrong with you. And every 15 years, you double the number of things that go wrong with you. And so between the age of 75 and 90, you're doubling, and that's probably the last doubling time. And then between 60 and 75, you're doubling all the things wrong with you as well. But that is a time that you can intervene and try and reverse some of those components by developing some good care plans and treatments. Next slide. So this is really busy, and all I wanted to show you was that in this tool that's on the right-hand side of the scale of the slide, these are the health deficits that I mentioned earlier. So it could be your memory, it could be your mood, could be your motivation, your sensors like vision and hearing, your speech. And then in the middle would be your activities of daily living, like are you able to feed yourself and care for yourself? And then if you need help with other things like cooking and shopping, driving, etc. And then on the bottom are social things like, do you have enough income to make ends meet? Are you still married? Do you have a caregiver, etc. So these are all these deficits that we tick off. And depending on how many things you tick off, yes, that would lead to an increase in your frailty index. Next slide. So the frailty index then is a number of things that are wrong with you divided by the total number of questions. And if you have nothing wrong with you, then you have 0. And if you have everything wrong with you, you have 1. But the scores are 0 to 0.08 would be non-frail. And then 0.09 to 0.24 is when you're pre-frail, and 0.25 and higher, we call it frail. And frailty index of greater than 5 really is associated with mortality over the following 20 months. And so it does actually give you a prognosis as well if your frailty index is higher. So next slide. But the good A is for activity. Can you hear me there okay?
Yes.
Okay.
Yes.
V is for vaccinate. And we heard about that earlier. And O is to optimize medication to ensure that we don't take drugs that are maybe not necessary, try and reduce the number of drugs, reduce the dose of drugs as much as possible, and really go over it on a regular basis with your physician to see whether you still need to continue with these medications and keep that down as much as possible. Interaction is hugely important, that's socialization. And D is for diet, using food as medicine. So as you get older, as you know, protein is really important. And so these are the 5 things that you need to keep in mind. And if you do the avoid and think about it all the time and live your life in this way, then you can avoid frailty. And the Canadian Frailty Network has a fabulous website with a lot more resources as well. And next slide. So exercise at any level of frailty. Certainly, if you're not frail, you should be exercising so you prevent frailty. But even if you have problems with mobility, even if you have problems in needing a cane or a walker, there's exercise activity that's going to be helpful for you. There's get up and go classes for people that are, using wheelchairs. And we've seen people graduate from get up and go classes and be able to go on to OsteoFit classes as they become more robust and less frail. And next slide. And socialization, of course, is hugely important. And the thing that we see often is social isolation and people that are living their lives with loneliness. The social isolation is a definite health risk, and it's been associated with depression, dementia, and even earlier death. So the 3 Ds. But there's social risk factors and health risk factors. And so even if we don't have a person that's socially isolated yet, if there are risk factors, then we can intervene and offer them support. So people that live alone or who have had life transitions like loss of a partner, recently widowed, those are the people that we really worry about. Those that really recently lost their transportation, lost their driver's license, those living in rural settings with not a whole lot of community support, small social network, small cultural groups with English as a second language, etc. And then in the health risk category, people that have mobility problems, chronic disabilities, people with psychological, cognitive disabilities, early dementia people, they're the ones that really are at risk for social isolation. And so as healthcare providers, we always look for those risk factors and try and intervene. But with social prescribing, this is where we really can intervene as well. So the idea of social prescribing, which I'm going to hand over to Margaret to talk about, comes from the UK, where they've shown that 20% of the visits to their family physicians were things that are associated with social issues and not medical. And as a family physician, I can say for sure, I've seen a lot of patients come into my office with social issues that really didn't need medical intervention, but needed somebody to really understand their situation in life and provide them with that support. And in UK, they've shown that through social prescribing, they've actually been able to reduce a number of visits to hospital and to family doctors. And so this is just increasing the health of the population. And the next slide, which is my last slide.
I think that is it.
That's it. Okay. So
now you have learned about frailty. We can get to the other topic, which is how social prescribing can support you. And so we're going to do a little info on what it is. So what social prescribing is, it is a mean for healthcare professionals to refer people to a range of local and non-clinical services. So services in their community and as non-medical. And you've already heard UK several times today, but the idea did originate in UK since the late 90s, actually. And right now, just in this year and a bit last year, it has become a long-term strategy for the NHS. So they're building and integrating social prescribing into their health system. So that is UK. And in Canada, it is something that is still growing. So there recently is actually a new organization developed called CISP, which is Canadian Institute for Social Prescribing. And they're based in Ontario, but they're really helping that effort to bring social prescribing together in Canada. But there are currently different separate projects in Ontario and BC and Alberta that is about social prescribing. And today we're mostly going to share with you about what is happening in BC in terms of social prescribing. So they are programs that are funded by United Way. And there is one seniors community connector like Sandi in each of the city right now. And where my role and Grace's role kind of comes in is from Fraser Health's perspective, we really want to support this integration so that everyone can access social prescribing and your care providers will be knowledgeable about what it is so they can support you on this. So in BC specifically, our social prescribing program is for older adults. So it's a way for healthcare professionals to refer older adults to local and non-clinical services. And I realized before I move on to this slide, I never really talk about why I'm here. But I work for Fraser Health with Dr. Grace Park, and I'm a social prescribing change lead. So the person that's trying to help support this integration. And that's why today we really want to share with you what we're doing and how you can access these resources. So this is what we mean by social prescribing as a process. So here on the left-hand side, we have an older adult. And when they go to the healthcare providers, if they express this need, or the healthcare providers maybe use that frailty identification, or during their care assessments, they realize that there's a need for non-medical resources. So then the healthcare provider will make a referral to Seniors Community Connector. And then from there on, the community connector will get in touch with the client and do a full intake and tailored wellness plan to really figure out what you need, what you prefer, what are some barriers that maybe has been preventing you from accessing resources, and then to really guide you and to do it step by step with you to figure out what resources are available and how you can access them. And some of the resources could include back to healthcare services. It could include transportation, for example, helping you fill out application for HandyDart, or providing taxi vouchers, volunteer drivers, or it could be housing, which we know is a big consideration and big thing that needs addressing in BC. So it could be about housing. It could be about social activities. So peer support groups, it could be walking group, book club. It could be also for nutrition support. So accessing food bank, how to apply for that. Maybe Meals on Wheels, maybe it's a hearty meal that is designed for people with heart condition or specific medical concerns. It could be physical activities like yoga class, or maybe just even getting a physical activity pass into the community center. So it can be very diverse, but the Seniors Community Connector is the person who is very knowledgeable about what is available in your community, and they can support you through that process. So really, it is a team approach because it is a plan tailored to you, and then it's a partnership with your Seniors Community Connector as well as your healthcare provider, because after talking with you and developing the plan with you, the connector actually sent back a care plan back to about these non-medical needs back to your healthcare provider, so mostly the GPs and NPs, if you have one, and then so your healthcare providers can also know how to integrate these care plan into your healthcare. So it's not just medical, and it also addresses the social needs. And before I get here, any questions about what social prescribing is? Okay, no worries. We still have many slides, and we have a bunch of time for us to talk. So talk together. So how you can join social prescribing, or how you can share with your friends and family, let them know about social prescribing, is if you live in the Fraser Health region, because since we're doing a bigger integration and partnership, it is available anywhere. So if you go to a walk-in clinic, if you go to your family doctors and nurses, they know about social prescribing, you can mention it to them and ask for that referral, and they'll be happy to talk with you about this option. And sometimes, possibly, your doctors and nurse doesn't know about it yet, and there would be a great chance for you to let them know this exists and it's something you want to learn about. And if you or your family is involved with home health, the home health team also knows about social prescribing now, so they can help make that referral. And also the social workers, the PT, so physiotherapists, the occupational therapists in Fraser Health, they also know about social prescribing now and can help with that referral. And we're also working with several hospital units, so then when people are being discharged from hospital, that the hospital staff can either encourage social prescribing, or you can let them know about there's this thing called social prescribing and you like to be referred to it. And there's also the Fraser Health Virtual Care, which is a phone lines plus a online consultation with the nurse. So that team also knows about social prescribing. And when you talk with them, they can help identify that need. And two other method is BC 211, which is a phone number available for everyone. And it's kind of like 811, but 811 is more health oriented, while 211 is more community resources oriented. So if you have any questions regarding community services, 211 is a great number to know. And pathwaysbc.ca is another website by the Division of Family Practices. So you can go on and find a bunch of community resources in your area. And in the case that if you're not in the Fraser Health region, we don't have that integration just yet since we're from Fraser Health, but we really encourage you to talk with your family physicians and NPs, and they should have access to where the community resources are and can support you in helping you to find out. And also there is still the BC 2-on-1 where you can ask them about social prescribing and ask them where you can access this support. So I'm just, oh, sounds like what I keep saying, I know. Thank you, Marla, for the comment. And if you just need some info, so for example, you don't really need a connector there to do every step with you and then to fill out each form with you, you really just want some info on where these resources are and where you can find a transportation service or where you can find a certain resource. We encourage you to use the pathwaysbc.ca website if you're in the Fraser Health region, and we encourage you to call BC 2-on-1. It is available 24/7. It is free. You really can just either text 211, like to the number 211, and then type your concern, or you can call 211 and there is a navigator on the other hand, and they can support you on finding the resource you want. And it's confidential and it's also multilingual. So we really want to promote this. If you know how to access resources, you just need a few phone numbers. But if you're your family member or your friend or anyone you know, they really need that hand holding, or that confidence building, or really need some help to remove barriers, or it's a bit more complex and they would need someone to do it with them, then social prescribing is a really good way to start. And on the other hand, if you're listening to all of this and you think, well, I don't really need any support right now, but these seems pretty cool. All of the social prescribing programs are recruiting volunteers. And this volunteer role can really support the connectors in supporting more clients. So if it is something that you're looking for, they're always looking for volunteers. And maybe Sandi can talk more about it when she shares her stories. But volunteers are vital in this process. And I'm just going to check the care box right now. There's for Surrey residents. So I see that Chi Ing, you shared that a website that is by diversity. So that is for Surrey. And then for other cities in Fraser Health, there is also social prescribing. So for example, I see some people today are from Burnaby. There is one in Burnaby, which is by Mosaic. There is one in Maple Ridge and Pitt Meadows. There's one in Tri-Cities, White Rock, South Surrey. There's one in Chilliwack. And Chilliwack actually covers Harrison and Agassiz. And there's one in Mission as well. I saw someone is from Mission today. So everywhere in Fraser Health, they all have a social prescribing program and a connector that can support you. And in terms of Vancouver, I believe there are 3 programs depending on which area you live in, but there are 3 social prescribing programs that can support you. And on Gabriola Island, actually, there is also a social prescribing program, and there are a few in other areas. I'm just not an expert on it, but I would love to help if you'd like to share me which area you're in, and hopefully I can give you some info on that. And the third part is we really want to invite Sandi to share stories and how she has supported many clients with social prescribing. I'm just going to check the chat box one more time just to make sure I didn't miss anything. And I see Bob's comment about the paramedics and firefighters. So that is wonderful. And we're really hoping that more people can know about it and we can even integrate it better so more people can access it. Is there any other questions anyone would like to ask before we invite Sandi to share more stories? No? Okay. We still got time, no worries. Sandi, would you like to introduce yourself to everyone?
Hi, I am the Seniors Community Connector for working out of Community Services Building. I look after Pitt Meadows and Maple Ridge, and I have been in this job for just over 2 years now. I was brought on at the beginning of COVID, which made it extremely challenging on my end because first off, I was trying to get into the doorway of the clients that referred over to me, and then finding the resources that could help them during a pandemic was definitely a challenge. What I did first off when I got the job was got my RAC cards made up, went around to the walk-in clinics, the Salvation Army, the food bank, anybody who would let me in the doorway, basically. I introduced myself, said, this is what I'm doing. I'm here to work with you and not against you. And how can we support the seniors in our community? And at first it was not really received well, and people were like, oh, no, you're here to work against us. But then eventually the doctors got on board and started referring clients over to me. A very large portion of my clients get referred to me through urgent primary care. Physicians, nurse practitioners, Salvation Army sends me people, the food bank, Fraser River Indigenous Society. They can self-refer, and family referral works very well also. My clients can be in need of social interaction, wellness phone calls, food bank registration, social activities, anything, any form of paperwork, filling out applications for Handy Dart, the taxi savers, even how to maneuver getting around the town in a bus. Senior center is a big one. And the senior center, I say to all of my clients that I've helped register with the senior center that I will do 2 or 3 classes with you, and then I will leave you on your own to make friends and that. So I have attended chair yoga, hula dancing. I play pool with a senior every couple of weeks, and I'm getting better at that. And beading is another one that is very popular, but it's just that my goal with my clients is to help them have a better, happier life living in their own environment and still feeling like they're a part of the community and still feeling like people care about them. So I have lots of good stories. Do you want my stories, Margaret?
Yes, please, Sandy.
Yes,
And I'm going to pull up a few pictures to help you remember all of those. Possible.
Yeah, so I'm very fortunate where I work because I have access to Meals on Wheels, legal aid, the party bus, and Better at Homes. So we do a lot of great activities with the party bus. We do picnics in the park, and we invite seniors from all the programs. So one of my seniors lives on the 3rd floor of a building without an elevator, and she cannot get out of her building. So when she was referred over to me, she had not left her building for a year and a half. Groceries were delivered to her, prescriptions were delivered to her, but she had not been outside for a year and a half. So it takes 2 to 3 people to get her down 3 flights of stairs and into the vehicle. And I took her to a outdoor party bus event where she just sat in her chair, and we had tears because this is the first time she's been outside in about a year and a half. And this is the first time she had been around anybody other than the people that are dropping her groceries off at her doorstep. So we sat in the park with her for 2.5 hours while she had lunch with a bunch of other seniors. And there we had live entertainment, and she cried because she had not been outside around other people for a year and a half. And that just made my heart very happy. And we continued to carry her down 3 flights of stairs in her apartment and load her up into the car to go to other events, which is very heartwarming. I can't imagine being locked up in your apartment for a year and a half, not having any kind of social interaction. So we have that happy story. And then we have another story about a person who she had contacted 211, and she was in desperate need of groceries. She had 2 cans of tuna left in her apartment, and that was all she had to eat. And she was prepared that this was the day that she was going to die in her basement suite, and nobody would find her until her landlord came to look for her rent. And I got her number that day, and I phoned her, and she actually answered the phone. And she cried because somebody was actually caring about her. She didn't want to give me her grocery list, but she gave me her grocery list, and I went and got groceries for her and took her over her groceries, restocked her cupboard with food, got her registered with the food bank, and she has regular weekly delivery now. Got her prescriptions filled for her, which she had been without those for probably about 2 months now. And set her up with a volunteer that does wellness visits and phone calls with her. Then she started going outside, and then she was on her scooter one day and was hit by a van while she was crossing the crosswalk. So then we had to navigate ICBC with her and claim, getting her a new scooter, getting her scooter replaced. And to make a long story short, she calls me her angel. And we have now moved her into the apartments above where our building is. We have 95 affordable housing units. Got her into one of those buildings, apartments, got her registered with the party bus. She is attending events regularly now, and got her rent subsidized. So now she is a much happier person, feels like she's an active participant in the community. And that's the goal for social prescribing, is to let them know that even though you're aging, you can still be an active participant in your community, and you still matter, and people still care, which I think is a lot of people are missing out on, and a lot of people are missing that in their lives, that their kids grow up and they all have their own lives, and they just kind of get forgotten, which is really heartbreaking for a lot of them. I just saw one of the questions, Margaret, that they can self-refer. And yes, I do take self-referrals as well. I get quite a few self-referrals actually. And they just need to know that, I think once they realize that there's actually resources that they can access to make their life a little bit easier so they don't have to struggle so much is a big thing in this program. I can carry on, Margaret, if you want me to.
I would love you to continue, but I saw that there are several comments in the chat box. Is it okay if we address those first, and then
absolutely
more? Thank you. So I see one from Andy. I addressed it a few above, but I saw one from Andy mentioning about the age and how I don't know if I think everyone can read it. But they're young oldies, middle oldies, and old oldies. And I just want to say I really appreciate that comment, because Andy, that is one of the challenges with always trying to mitigate, is that perception on aging. And then we know that on the slides it says older adults, but we know that social prescribing really should be able to support everyone. Is due to the limitation for that funding right now, at least in BC. The programs can specify that we can only support older adults. And I know that older adults mean different to everyone, and that's why in most of the public facing material we don't want to put any age. So there's one note that I want to make. And then the other thing is, we know that through working with different stakeholders, that there are many people in their 40s and their 50s that don't really categorize as the social term of older adult, but they also really need the support. And that is something we're continuously to try to navigate. And we really need to, and we really want to help bring out that need to the government, to the funding agencies, to let them know that it's a little more complex than we think. So just want to acknowledge that. And I wonder if Sandi and Grace, you have any comments regarding that?
I can tell you my youngest is 52 and she is in assisted living. Was driving down the road one day and had a massive stroke and drove her car into a telephone pole. And she's paralyzed on one side now. And so she is in assisted living out here and is the youngest. And I can tell you that my oldest is 91, is my oldest. I don't turn anybody away. I don't not accept them because they're either too old or too young in anybody's mind. I will talk to everybody, and if I can help them, I will definitely help them.
So from my perspective, we rather not use the number, the chronological age, because the physiological age, the biological age is really more important. You can have people that are in their 50s are more frail than those in the 90s because of that variability in aging that I spoke about in the beginning. And also when we look at some of our Indigenous population, we see frailty in much younger age. And then, of course, those with neurodegenerative conditions like multiple sclerosis, ALS, people that are paraplegic from accidents, they can have frailty and need help with all their activities of daily living at a much younger age. So we'd rather work with functional age rather than the chronological age. And so when we work with our service organizations in the community, we try and look for that flexibility, and Sandi is wonderful that way. But it really does talk about, what kind of a caseload there is and if they're serving a large population. So that's where the funding comes in, and the funding that we've secured is really to address the older adult. And that's why we've sort of been talking about the senior age group more, but that's the background.
Thank you, Grace. And I'm gonna bring it back up in the chat box. I saw there's few about frailty, so Grace, if you can help us answer some. To what extent do common medications contribute to frailty?
So medications can be very necessary. And so we don't talk about numbers of meds anymore. We talk about whether they're absolutely necessary. And then there are those that maybe have been prescribed in the past, and sometimes they're prescribed to reduce the side effect of the first medication. And so we look for those sort of meds that may be unnecessary to try and reduce the number of medications all in all. Medications in themselves certainly have side effects, but wouldn't say that any one medication would contribute to frailty unless you've got side effects that are really affecting your function. But overall, it's looking at the number of drugs that you need, which reflects maybe the number of medical conditions that you're having to live with. And so it's the polypharmacy, is the number of drugs that maybe they're not all necessary. Maybe they can be discontinued over time under medical supervision. So that's what you need to talk to your primary care provider about, is do we really need to continue with all these drugs? And in the hospital, you got started with sleeping pills and things like that. Do we really need to have them after you get home, and to try and get off of them as much as possible? Hope that helps.
Thank you, Grace. And that ties into really well, actually, to the second part of that question, is that since Frailty Index require a GP assessment, what is being done for the million people in BC who don't have a GP?
That's a really great question. And I keep watching all of the ministry news around trying to incentivize people to do primary care, to go to the universities, to try and encourage young, medical students to go into primary care, et cetera, to try and increase the number of family physicians, because that longitudinal care, that the support that you get from somebody who knows your health status and follows you through your health journey, that's so important. The frailty index is something that we talk about, in the field of geriatrics and in the field of frailty research. But you don't have to have a frailty index. You basically can speak to your provider, or you can check yourself. Go to the Canadian Frailty website and you'll be able to check yourself to see how frail you are. And it doesn't have to be a frailty index, but maybe you can identify yourself as being, living well. And so clinical frailty scale of 3. Or you might be starting to get slowed up, needing a little bit of help. So that might be pre-frail. So if you identify yourself as being at one of those categories, then you can talk to your healthcare provider, or you could talk to anybody that can support you to improve your lifestyle, so that you can get improvement in your diet, your food security. You can get better support regarding getting to exercise activities, increasing your socialization. The avoid strategy, if you can do the avoid all by yourself, then you can actually help yourself to live well and to have that healthier lifestyle. So doing a lot for yourself is really great if you're able to. Getting support from your family caregivers is really helpful if you've got somebody to help you to source out these things. But the social prescribing then is for people who really need that extra help to be able to really see what's available for people, whether it's, appropriate for them culturally, whether they need help financially to be able to access some of these community supports. So that's where the social prescribing comes in as well. So you can refer yourself if you don't have a family physician, but all that to say, I don't have a solution for if you do not have a family doctor. In the short term, you can go to the local community division of family practice website, and they usually have a number where you can register to find a local family physician. And some communities actually keep a list of doctors that are accepting new patients. And so division of family practice in your community would be a good resource.
And Sandi, did you want to say something?
Yeah, I know in Maple Ridge, we have the Division of Family Practice, and I'm always checking on their website to see if there's doctors taking new patients, and we always seem to have doctors taking new patients out here. I've helped quite a few seniors find a doctor out here, and it's I know not every community has that, but we're very lucky out here that we seem to have doctors regularly taking on new clients.
Thank you, Sandi. And I saw a comment from Andrea mentioning that perhaps we could self-check our frailty each year and get heads up on the changes. And I see Grace nodding. I think that's something that Grace always want to promote. And we mentioned that when we speak with the care providers as well, that if us as a patient, that we can mention frailty and really advocate that for ourselves, that is another great way to get the healthcare providers and your GP starts doing those, because it's not supposed to be one way around. We should advocate for ourselves too. And that is really going to encourage your healthcare providers to help you and support you in monitoring that. So thank you for that comment, Andrea.
Yeah, absolutely. I agree with that. And there are tests that you can take for yourself. And again, going to the Canadian Frailty Network, you see some of the tests that you can actually think about, testing your memory. There's little tests that you can do, like drawing a face of a clock, things like that you can sort of do with your partner or with members of your family. And then mobility, seeing if you're starting to have problems with weakness in your legs, you can't get up off a chair like you used to. These are points of discussion that you can bring to your family doctor. If you can find one, if you have one, it's really great to be able to point out, I'm not as active as I used to be because I seem to be slower. And, is there something I can do about that? And that will be a really great discussion to have. And it might be that you should take some exercise and they can direct you to the appropriate program.
Mm-hmm.
Yeah.
Yeah, and there are tools around. It's not that there's no tools. There are tools, but if you could help your providers recognize that you need that, then they can support you on that. So thank you for that comment. I see quite a few now, actually, but I'm go back to one before we miss it. Barb was asking Grace if you could mention about bone density.
Sure. So bone density is, you know, as you get older, and particularly women in the postmenopausal years, you can lose bone density, which means that you're at increasing risk of fracture if you were to fall. And so there is a test that you can get done. And again, your healthcare provider would order that for you, and is to see how dense your bone is, and it compares you to a standard according to your age, and it tells you what your score is. And then if you're sort of below a certain score, then you're at a higher risk, and then your doctor might recommend that you go on to a bone building medication. So that would be a way of assessing whether you have thinning bones, so that'd be osteoporosis. And before you get to that stage, you might have what we call osteopenia, which means that it's getting thinner, but not yet at the cutoff where we would call you osteoporosis. But things that you can do on a preventative level is to ensure that you have good calcium intake in your diet. And if you don't drink milk and have a lot of dairy products, you might want to take calcium supplements. And vitamin D in particular will help you to improve your bone density. Use your calcium that you take in, and has been shown to decrease falls, I believe. And so, but calcium and vitamin D are good supplements to take, and ensuring that you have calcium in your diet with some dairy intake. So that would be a preventative thing you can do. And then, of course, a screening test you can ask your family doctor about to see where you're at. And then there's some treatments for those that are already at osteoporosis, or if you think you're at risk. The other important thing is the weight-bearing exercises that you can do. So weight training, walking activities, all of that will increase your bone density also. So that's a conversation you can have, hopefully, with your family doctor.
Thank you, Grace. That's amazing. And so just going down by order, see a question about, could you mention a little more about the homeless and about the substance use portion of our population that may really need social prescribing, but a few people would go near them to help social prescribing with their group? Sandi and Grace?
Yeah, certainly that's a big problem, the homeless or vulnerably housed people. Certainly the substance using crowd also, they need a lot of help. The mental health program in Fraser Health has outreach services, and they will go out to people that are, you know, homeless, substance using people, offering them, you know, even temporary housing, or see if they would qualify for subsidized housing. So all of that is another sort of program in Fraser Health. Social prescribing has not gone in there sort of intentionally, but the mental health program will reach out to community nonprofit organizations regularly and have really great connections to help those people. So that's a different sector, and we haven't focused on that. So I'm not able to answer the question in great detail, but recognize, of course, that they are a population that's vulnerable and need to be addressed as well.
Sandi, do you have any thought on that question?
I work a lot with Alouette addictions, and I don't have anybody that is homeless that has come off the street asking for help, other than one client who was evicted from her apartment and found herself living in her car with all of her belongings and her dog. And I ended up working with Alouette Addictions, where we got her into one of the modulars. We were able to, she started off sleeping in Salvation Army, where they let her take her dog with her, and they were feeding her dog as well. And then I worked with Alouette Addictions to get her into one of the modulars, where she is now living with in one of the modulars with her dog, has her own room and her own little kitchen and bathroom. And one of the caseworkers from Coast Mental Health is now working with her.
Thank you, Sandi. And I know that another thing that we're trying to do along with social prescribing is signposting, which is that social prescribing piece. And we do have a few resources that we're going to show you in the end. But what we're really trying to do is to promote that BC211 number and then to showcase it and let people know that there is this number where you can ask for any support on community services. So right now we have those posters and pamphlets available. And what we're doing is we're trying to get it to as many places as possible. So we do have the link for those if you want to support us on that. And we do work with at least within Fraser Health, so they can go to any social housing or any food bank, even casinos, community centers, anywhere really, anywhere and everywhere to really get those news out that there is support available for community resources. So just want to mention that as well. That's something that's happening. And the next question I see is from Lynn. Is the Provincial Health Services Authority assisting health authorities initiating social prescribing in their regions? ? And is it getting provincial funding for that? And where will advocacy make a difference? Grace, I think you'll.
Yeah, that's kind of a tough question. The PHSA does not really assist local health authorities with their specific programs like social prescribing. PHSA looks after things like the cancer clinics, and I think maybe the Children's Hospital falls under PHSA. So it's not directly supporting social prescribing in the health authorities. So the social prescribing program that we're working with in Fraser and in different places in British Columbia is funded through United Way, which is funding coming from the Ministry of Health directly to those communities. And Fraser Health was really fortunate to be able to get several of those grants so that we could have a connector in almost every community in Fraser, which was really, really helpful. So advocacy, I think when there's definitely advocacy happening, and the whole idea that social prescribing is important and a way of preserving good health as we get older, I think is something that's out there and catching on. There's lots of studies and research going on in different parts of the world that says social prescribing will help to promote wellness and at the same time contribute to sustainability of healthcare systems. So all funding agencies are looking at social prescribing as a way of doing those things. And all the work that we're doing, we're being evaluated very closely to ensure that the seniors, older adults are appreciating it, they're enrolling in the programs, and that they're benefiting from it. So the evaluation is what's going to tell the funders, the government, that these programs are worth funding continuously. And so we're in the process of that now through United Way.
Thank you, Grace. And the next question is on, can you speak to the social prescribing support for non-English speaking people and culturally appropriate social prescribing? So Sandi, do you want to?
I can take that. Yeah, I can take that. I've had a few referrals over to me where their primary language has been Spanish or Mandarin or Punjabi. And where I work at Community Services, we have a database of the people in the building that we work with that speak other languages. So I've been able to access that. If I have not been able to find something, I was on a COP Zoom the other day where I needed Punjabi, and one of the other seniors community connectors had people that they work with that can speak that. So I was able to connect with them and get that resource. A lot of my referrals that are where their primary language is, let's say Mandarin, they are able to, they live with their children. And so I end up phoning their children and then booking in, and then I'm booking in when they're home so that they can translate for me. And it seems to be working well. It has its little bumps along the way, but I'm figuring it out. And I'm also able to access over 100 volunteers through the Better at Homes program, so I can put it out through that program as well if somebody speaks Mandarin, and then I can connect them with that volunteer and they're able to help them also. So it's working so far. It's good.
I can add to that. So there are communities in Fraser Health where we do have a lot of ethnic groups. And so in Surrey, we have a lot of South Asian patients or people living in the community. And in Burnaby, we have a lot of multinational groups, of course. And so the organization Mosaic is the one that we work with. And they provide the interpretive services. Their flyers and their rack cards are in different languages, and they have programming that are culturally appropriate for people. And so it's really wonderful to see, people that were recent immigrants to be able to access, cooking classes. They're multicultural and they see that they're not alone. So these kinds of venues are wonderful for socializing for people that are new to the country. And so I just wanted to emphasize how important these community organizations are, because that can't be created in a healthcare system, but these nonprofit organizations are aware of the needs in the community, the population they serve, and so they are able to provide the culturally appropriate services.
Mm-hmm. Yeah, thank you, Grace. And I want to add too that it is something we continue to try to improve on. Like, for example, today's presentation is in English, and it could be in many, many languages, but it's in English for now. And we also, when we educate the different care providers about social prescribing, we also ask them to please include the client's primary language on the referral form, because the referral form is really the first thing Sandi and other connectors will ever receive. So you really want to make sure the first step is right, like make sure even that first phone call, someone will understand what's happening, and so they can actually access the support. So that is another way we're trying to do that. And when we're developing different promotional materials for social prescribing and 211, we try to have them in as many languages as possible, and we're still adding to the list. So those are some things that are happening. And I just want to share a quick story, actually, because we worked with the Aboriginal Health group to try to set up social prescribing as well. And although that is still in progress and still has a lot of work to do, but something that's very interesting is that when we share with them their resources, it was actually their NPs and GPs that took the initiative, and they're like, yeah, no, I'm not posting this in my clinic. This is not culturally appropriate enough for us, and we're not going to use it until it is. So then we did take that process to communicate with them and then let them actually take charge of what they are looking for. So then social prescribing can become a process that makes sense to their population. And then that makes sense that the patients, when they see something, that they will actually respond to it instead of just like, okay, this is just another thing that I don't need to learn about. So those are just some small examples on what we're trying to do, but that is a great comment. Thank you, Susan. And the next question, comment from Andrea. I'm a rehab assistant and I see family members in denial about the ability of their parent to manage alone. So Sandi and Grace, any comments on that?
I'll start on that. I think we have to be really careful to see, whether it really is denial or is it lack of understanding, and do they need some more support and education about what to expect. And if we were to give them the information, then they can use it when it's appropriate for them. And we also have to worry about burnout of caregivers, because they're looking after their loved one 24/7. And perhaps what appears to be denial might be a period of burnout and they need some respite, they need some help. So those are some of the things that I think about. And, if a person they say things like, no, there's no way that my mom's going to fall. Well, you just have to give them the information of what to do to prevent the fall and to be able to respond to a fall. So those are sorts of things that we can do. But giving them the information so that they can use it when it's appropriate, I think is being, the most responsible as care providers. Yeah,
Thank you.
I'm a senior with a parent who is in denial about needing support. That's more what I see. I think the caregivers are really worried about their parents falling, but then the parents are the ones that are shooing their adult children away and saying, I'm just fine and I can do this and I can drive. What do you mean you're going to take my driver's license away? And these are things that we have to constantly worry about. Yeah, and if you're a senior yourself already, then you're having to take care of your health, and then to worry about an elderly parent who's not willing to take some precautions, that can be very difficult. So again, getting some help, I think you should look at caregiver support for yourself to see what other people may have been doing. The caregiver program in BC, they have really great educational material and you learn from each other. So that might be a venue for you. Yeah, and I think your elderly parent knows what would happen, what the consequences would be if they were to have a fall, or if they were, not able to have nutritious meals, etc. And so you do need to provide what you can, but take care of yourself as well.
And I want to invite Sandi as well, I wonder, because I know that there are so many times that probably when you call someone and they're like, oh no, it's fine, like my healthcare provider signed me up for this, but no, it's all good. Any thoughts on that? Any stories you want to share?
They're always fine. They're always fine. They always think they don't need help with anything. But then once you start talking to them, the whole story comes out. And it's extremely hard for a senior when they lose their driver's license, because they're losing their independence. And once you start talking to them that, yes, you can lose your driver's license. Like, for example, I had one who was not supposed to be driving, but she still kept driving. And she wasn't telling her doctor, but she still kept driving. And then she backed her car out and she backed into a tree. And so then I'm talking with her and I'm like, okay, well, that tree could have been a person. And then where would you be right now? And she's like, oh, right. But how am I going to get my groceries? And, how am I going to get to my hair appointment? And how am I going to get to my friends for coffee? And then you start talking to them about the services that are available. We can deliver your groceries. We can set you up with a volunteer driver who can take you to your hair appointment and drop you off with your friends for coffee. And then they realize that, they're not okay. They do need the help, and they're still going to have a life with the help that with what is being taken away from them, they can still have an active life, and it works really well. Caregiver support, I can't say enough about that, because the amount of people that are referred over to me because they are burnt out from being a caregiver is huge. And there's so many resources out there for them to make it so much easier for them, that once they realize the resources that are available to help them, they're not regretting looking after the person that they love. So it's huge, and everybody should access it because it really makes a difference.
Thank you, Sandi. And I guess I'm seeing that there's no other question, so I still want to share the story that we heard from UK, actually. And Grace and Sandi, you probably know the story by heart now, but but there was the story for a gentleman who visited ER so often in 1 month, and then every time he goes in, he complains of chest pain. But then after they do all the exams or the blood tests, then nothing is wrong medically. So then he got sent home, but then he would come back again with the same complaint. So then the ER nurse referred them to social prescribing. And then the first few phone calls, when the connectors call, it is that same answer, just as we were talking about, like, oh, it's fine, it's just my chest pain, everything else is good, I feel supported. But then as the relationship keeps building, then just like Sandi mentioned, the story unfolds. Then the connectors find out that the gentleman actually lost his spouse recently, and then when his spouse was around, the two of them would sit on a couch and talk about their day together. But then since his niece is not so comfortable anymore, he couldn't sit in that couch anymore, and he also doesn't have anyone to speak with. And then that's when he started to visit the ER with those chest pains. So then what the connector did was then they made the plan with the client, and they actually went to get a new couch together, and the couch that he can actually stand up and sit down on, and where he can relax and unwind from his day. And then they set him up with peer support groups that he has someone to talk with. And he has never visited ER since. That is the very brief recap of that story. But I just really love to share that, because that really highlights how it's really not something, it just seems so trivial sometimes, how something so little, it seems, can help someone, and it doesn't require fancy medical machines or like expert doctor, well, we always need expert doctors, but like expert services to help someone and change their life. And that is something we really hope social prescribing can bring people, and just passionate people like Sandi and all our other connectors. That is the beauty in it, and we are just very thankful we can continue to support this.
I can follow up that story, Margaret.
Yeah.
I had a referral over to me of a very lovely lady who was looking for, she was referred to me for social interaction. So I contacted her and went and visited with her, and found out that she has newly moved, her and her husband newly moved into an apartment. And she came from a very, very nice house with a very big yard where she had a flower garden and she had a vegetable garden, and her husband would go out every day and do his thing, and she would wander around in the garden and plant and water everything. And now they are living in an apartment, and she felt very isolated. And so I said to her, I'm like, well, if you could do anything, what would you really want to do? And she says, oh, I want to quilt. And I'm like, oh, okay. So I'm looking around this 1-bedroom apartment, and I'm like, I don't see a sewing machine. So I said to her, I'm like, do you have a sewing machine? She's like, no. I said, have you ever sewed? And she's like, no, but I want to quilt. And I'm like, oh, okay, well, let's see what we can do. So in Maple Ridge, we have the Quilters Guild. I contacted the Quilters Guild, and I said, I have this client who wants to quilt. She's never sewn before, but she's feeling very isolated, moving from her house to this tiny apartment, and she really wants to quilt. So they set her up with a sewing machine, and they started her on making the little heart pillows that go to the heart patients in the hospitals. And they started her off with 10, showed her how to thread the machine, and she made these little quilt pillows in like a week. And then she phoned me and she says, I'm done with the quilt pillows. I want something else to do. So make a long story short, she now has this really nice sewing machine, and they are going to her house. The person who runs the Quilters Guild is going to her house every week now, and they are now teaching her how to quilt. And her husband phoned me one day, and he's like, I really need to talk to you. And I'm like, oh, okay, I'm going to get in trouble for something. And he's like, thank you for giving me back my wife. He's like, she gets up every day, she's happy, she sits at that sewing machine, and he's like, you have given me back my wife. So something as simple as I want to quilt was what she was referred over to me for. And now she's super happy and quilting and making new friends, and her husband's happy.
That's amazing, Sandi. There's so many stories like that. So many stories like that. Wendy is mentioning the man from UK sounded that he had early symptoms of broken heart syndrome, the emotional type. I wouldn't know. Possibly, but I wouldn't know. But it's just things like that. Like you would never think that if you go to a clinic that maybe a couch is your prescription, or a quilt or a quilting skill is your prescription. And those are just something that's so unique that we hope that can continue to happen. Is there any other comments or questions? Anyone want to unmute and share any stories? We're just very lucky that we have more time today. Grace and Sandy, anything else you want to share before we finish?
I would just like to say that I think I say this at everything that I talk at, that, you know, it's inevitable. We all have aging parents, we all have aging grandparents, and we're all going to age. And I can only hope that programs like this are available for me to access as I get older. Because really, all people need to do is reach out for help and say, you know, this is what I need. What can you help me with? Like, what is out there? There's so much out there that people don't know about. And, you know, I've been given the gift of making people's lives much easier. And I'm grateful every day when I wake up that I have a roof over my head and food on my table, because the people that I meet in this job, they're struggling, and there's no reason for them to struggle because there's so many services that they don't know about. And I'm lucky enough to know what services are out there. So I want people to knock on my door every day and go, you know, I have a problem. How can you help me? Because it's out there and people just need to ask for the help. And I hope when I get older that it's still around and I can access it.
Well, we'll keep working on it, Sandy. I just want to say, I think it's really important that we open ourselves to the notion of reaching out early. So when you're still, you know, functioning well in your community, to make it an acceptable thing to reach out to community centers for programs, community organizations to learn about different things, and, you know, clubs where you can socialize, like the quilt club or wherever you might want to get together with like-minded people. And, you know, for men, we have the men's shed, and this is where men get together and have common interests that they can share and talk about. So to do this early, I think, is really important, because then when you get older and say you do have problems with your memory or you have problems with your mobility, then you can start reaching out for more help, and you might need more intensive help at that point and need connection to the health sector, and say you need to get somebody into the home because you need help, you know, with supports in the home, etc. So the idea of reaching out, I think, is something that we should start early, and to be watching for neighbors who are isolated and to work with them to try and make small steps to reach out as well, because we really do need to reach out to those that are tending to be socially isolated.
Yeah, thank you, Grace. And I guess some words I will want to add is that we hope that today's presentation is not just something you see and then you can kind of forget about it, because you are a very vital part as well in this. Like, whether you can share this info that you learned today to any of your friends, maybe your doctor or the nurse you know, or maybe it's for yourself, to your family member, to a neighbor, that would be very, very helpful. Like, I started as a nurse and I never knew this. I never knew this exists, but if one of my patients have told me, I would be so thankful for that. And so if you can share this information around, that would be great. We have some resources that I know Mary Lou and Christine can help us share out with the newsletter, some poster, or just some info in general, if you could help share that along, so more people can talk about social prescribing, and then more people will know how this can help people. That would be amazing. Or if you want to become a volunteer, we always need volunteers. So there's many ways you can help. And thank you so much for joining us today.
I will, end up the session then by saying there's one more little thing that we will, resource that we will provide you with, and that is, some of you may have seen the notices about it, but there is coming up very soon, October 20th, that's a shakeout week for BC, And you may recognize what it might be related to, and that's earthquake, being prepared for earthquake. We know that in BC, probably someday it will come. And so we want to know how to protect ourselves as best we can, no matter the environment that we're in.